you will realize immediately that um, in order for you to do any type of calculation, say you want to look at a gradient, you want to look at the valve area, uh, that involves Doppler. If you want to quantify, say, a regurgitant lesion, that's Doppler. So Doppler is again, it's an integral part of echocardiography. It allows us to quantify things, and so you will see that. So what we're going to do, we're going to look at what is the Doppler effect. When we talk about Doppler, what exactly are we talking about? We're going to look at the Doppler shift formula or equation. Uh, then we're going to look at the different spectral recordings. What these recordings mean. Uh, what about the shape? Where they're located. So everything has a meaning. Um, we have talked about pulse wave Doppler, so we're going to define what is pulse wave Doppler, what is continuous wave Doppler, what is color flow Doppler. So we're going to look at the whole spectrum of Dopplers. And so when we finish these two lectures, then you'll fully comprehend what Doppler is all about. Okay, so the first thing we're going to talk about is the Doppler effect. And this was first proposed by the Austrian physicist Christian Doppler in 1842. And what he observed is the phenomenon that, say, for instance, you're at a train station, or let's do it real. Say you're at the bus park. If you're at the bus park and a bus is coming towards you, and that bus, the driver, the conductor, someone has the horn blaring, and it's coming towards you, you're going to perceive that the intensity of that sound is increasing when it's approaching you. And when it passes you and it's going away from you, you're going to perceive that the intensity of that sound is decreasing. So let's fully analyze what we're talking about. We're talking about a moving object. So the bus. So the bus is coming towards you, and then when it gets to you, it's going to move away from you. So that is one concept. In addition to the bus moving towards you and then moving away from you, the horn in the bus is going. Someone is pressing the horn, and when the moving bus approach you, it appears as if that that frequency is higher, and then when it moves away from you, it appears as if the frequency is getting less. So these are some perception, because it is what you're perceiving. A couple facts is, yes, the bus is moving towards you and the bus is going to move away from you. But when someone press on the horn, that frequency that is established when they press on the horn is not changing, though. That frequency is not changing. What is changing is the perception when it approaches you and move away from you. So that is essential. The Doppler effect. So we use it's a moving object. When a moving object is making a sound, When it approaches a target, it appears to be having an increase in frequency, and then when it moves away, it appears to have a decreased frequency. And that is essentially the Doppler effect. So it's not nothing real fancy. And so if again, if you are, say for instance, you are right here and there's a moving sound, when it comes towards you, it appears as if the frequency is increasing. When it moves away, the frequency appears to decrease. Remember, frequency is just a number of cycles. So if we bunch up the cycles, that means it's increase in frequency. And if we space out the cycle, that means decrease in frequency. So it's not really a difficult concept to grasp. But if you have never think about it before, you know, and putting it in mathematical equations might be a little bit daunting. But again, when an object is moving towards, so we're going to relate this now to what we do, which is ultrasound. So when an object is moving towards a transducer, so if you are doing say you're doing a heart scan, and we're looking at blood or structure. So when we do ultrasound, say we do ultrasound of the heart, blood is going to move towards the transducer, blood is going to move away from the transducer. The different heart structure is going to move to and away from the transducer. So when an object is moving towards the transducer, just like the Doppler effect, the frequency observed is higher than the transmitted frequency. So the frequency that is observed, or the perceived frequency, is actually higher than the frequency that is actually being transmitted. And that is, you can relate that to the moving bus. I mean, when the bus is moving towards you, standing at the bus park, and the horn in the bus is going, that horn is transmitted at a fixed frequency. It's just because the bus is moving towards you, which is the blood moving towards the transducer, the frequency is observed to be higher than the actually transmitted frequency. And similarly, when an object is moving away from the transducer, the frequency observed is lower than the transmitted frequency. So that is the Doppler principle. And if we use delta F as the Doppler shift, and if we use uh, uh, FR as the receive frequency, so again, receive frequency is the perceived frequency, is what you are observing. And then F naught, if we use F naught as the transmitted frequency, the bus moving towards you, the horn has a fixed frequency because they just press whatever they do and to get a fixed frequency. That is the transmitted frequency. The Doppler shift equation is the received frequency minus the transmitted frequency. And then further characterizing the formula, you can say the Doppler shift is equal to 2f naught, which is a transmitted frequency, where v minus the cosine of theta, where v is the velocity of blood, because the transducer is going to look at the movement of blood, and then c is the velocity of sound in blood. So this is essentially the Doppler shift formula or equation. Now, this angle theta is the angle between the transmitted the ultrasound beam that is transmitted from the transducer and the moving red blood cells. Again, not a very difficult concept, because remember, when we did ultrasound physics, the sound wave is coming out, and it's like a linear thing, and it's going to meet the moving blood at a certain angle. And this is what we mean. So to give you a better, well, this is not what we mean. But anyway, so we'll get back to what that looks like. You need to have a visual of that. But what we're saying is, if if the um if the moving red blood cell is moving towards a transducer, this is a transducer, this is the red blood cell. If it's moving towards the transducer, the perceived frequency is higher, and we put, so it will bunch up the cycles. That means a higher frequency. But if the red blood cells are moving away from the transducer, the perceived frequency is going to be reduced, and we depict that as a widening of the or a spacing of less number of cycles, reduction in the frequency, increase in frequency. But if we were to relate that to the moving red blood cells, so if red blood cells are moving like this, and this is our transducer, which is gonna beam the ultrasound looking at whatever. The ultrasound, the sound wave is gonna come straight down, and it's gonna move. It's gonna meet the moving red blood cells at a certain angle, and this is the angle theta that we have in our equation right there. Okay, very important concept, extremely important concept. So transducer, ultrasound beam, moving red blood cell, angle theta. If you remember from basic maths, the cosine of 90 is 0. That means if this angle is 90 degrees, then you're not going to see any signal. You're not going to see any signal. Whereas the cosine of 0 is 1. So you're going to get the maximum, what we call the maximum Doppler shift. You're going to get the maximum velocity. So when you're doing your ultrasound, you have to put this into practice. You want to make this angle theta close to 0 as possible, so you can get maximum Doppler shift, you can get maximum velocity. So when you're doing ultrasound, you always are Doppler ultrasound, you always strive to get this angle close to 0, which means you want to get the ultrasound beam parallel to flow. You want to get the ultrasound beam parallel to flow so you can get maximum velocity. Okay? Cosine of 0 is 1. Cosine of 90 is 0. So when we talk about spectral recording, it's just a shape of you have seen these and we just run over them because you didn't have the background knowledge for us to explain. So the spectral envelope is just a shape of the say the flow across the mitral valve, the flow across the tricuspid valve, and we look at it in a certain graphical format, and that's what we call the spectral recording. So the spectral velocity recording, another basic concept is that flow towards the transducer. So if you have blood flow or even tissue flow, or tissue movement, it's not tissue flow, but if you have any movement towards the transducer, it is going to give you a positive deflection. What we mean by that, the recording is going to be above the baseline. You're going to get a upward shift in the velocity, and we're going to show you that what that looks like. So we using descriptive terms, but you need to see it. So flow or movement towards the transducer is displayed as a positive or upward shift in the velocity, and flow velocity away from the transducer. So if the blood is moving away from the velocity, it is displayed as a negative or downward shift in the velocity. And this is what we're talking about. So very basic concept. This is your transducer right here. This is the blood flowing, or you can have the movement of the heart muscle towards the transducer. So any movement towards the transducer is going to give you a spectral envelope above the baseline. So if this is the baseline, you're going to have a recording above the baseline like that. If there's flow away from the transducer, it's going to give you a spectral recording below the baseline. So it's going to be below the baseline like that. Okay? Okay? So these are basic concepts that you're going to need throughout your echo course and your Doppler and your Doppler interpretation. So flow towards the transducer, you're going to get a spectral envelope above the baseline. Flow away from the transducer, spectral envelope below the baseline. So if you remember what this is actually short axis at the level of the aortic valve, remember? This little depiction here is your transducer. So you need to know what your transducer looks like when you're doing your study. So this is the transducer for this study. Transducer is right there, short axis at the level of the aorta, and this is the cursor. The cursor is across the tricuspid valve, and you press Doppler, and this is actually continuous wave Doppler, but we haven't got there yet. So you press Doppler, and you get this envelope. So these are your spectral recordings. Okay, so these are the graphical representation of what flow you're having right there. Again, the Doppler is across the tricuspid valve, so something is happening across the tricuspid valve. Your ECG is on top. Systole is from the onset of the QRS to the end of the T wave, onset of the QRS, end of the T wave. So you have a systolic flow, because that's what the Doppler measures, and it's below the baseline. This is the baseline. This is the baseline. Again, remember your transducer is right there. So this is a flow away from the transducer because it's below the baseline. So you have your cursor across the tricuspid valve, and there's a flow which is moving away from the transducer. So it's moving from the RV across the tricuspid valve and into the right atrium. So this is tricuspid regurgitation. So the blood is going backwards from the right ventricle across the tricuspid valve into the right atrium. And then it's depicted here using Doppler. So it's below the baseline, telling you the movement is away from the transducer, and it's a systolic flow because if you just map it up to your ECG, systole is from the onset of the QRS to the end of the T wave. So you have a consistent systolic flow. Okay? Time is on the horizontal axis and velocity is on the vertical axis. So you can use Doppler to look at the flow and say exactly what it is. Let's look at, so again, this is two-dimensional echo apical four-chamber view. Your transducer is right there. Our cursor is across the mitral valve, okay? And you press your Doppler and your ECG is right there. Now you have a flow above the baseline, okay? So this is above the baseline. So it's actually two components. So there's one component here, another component. So there's two flows. If you map it up to the ECG, systole is from the onset of the QRS to the end of the T wave. That's systole. We don't see anything, but diastole is from the end of the T wave to the onset of the QRS. So we have a diastolic flow, and if you map it out, so we have this consistent diastolic flow, okay, which is above the baseline. So it tell you that there's a flow, something is flowing from the left atrium across the mitral valve into the left ventricle. It's moving towards the transducer, hence it's above the baseline. Okay, a flow from the left atrium across the mitral valve into the left ventricle, moving towards the transducer. So this is your normal diastolic flow across the mitral valve. So remember, when in diastole, when the mitral valve opens, there's a suction of blood initially from the left atrium into the left ventricle, giving rise to what we call an E velocity. And then towards the end of diastole, the atrium contracts and you get an A velocity. So this is your E and A velocity. This is your mitral inflow, because when the mitral valve opens, blood flow from the left atrium across the mitral valve into the left ventricle towards the transducer. Hence, it's above the baseline. So, knowing your Doppler shift formula is very important, because you want to make sure that this angle is close to zero as possible, so you can get maximum velocity. This angle you need to get close to zero. So your ultrasound beam should be parallel to flow. So when it's parallel, then your angle theta approach zero. Okay? So you get the maximum velocity, maximum Doppler shift. So very important observation. When an ultrasound beam is parallel to blood flow, the angle theta is zero and the cosine of zero is one. Thus, you get maximum velocity, or the true velocity. If it's not close to zero, the velocity that you're going to get is not going to be maximum velocity. It's going to approach maximum velocity, but it's not going to be the maximum velocity. When an ultrasound beam is perpendicular to the blood flow, the angle theta is 90 degrees, and the cosine of 90 is zero. Thus, the velocity will be zero. You're not going to see anything at all. So you have to understand that, because if you're doing Doppler and you're not getting any type of velocity, you might be just perpendicular to the moving structure or blood flow. So always assess Doppler in multiple windows. So when you're doing any Doppler evaluation, it has to be done using multiple acoustic windows. What we mean by that, different locations. So you're trying to get that ultrasound beam parallel to flow, because you don't know which location is going to give you that. So you constantly have to do your Doppler from multiple locations, and that's what we call windows, to get the most parallel beam to blood flow and hence the maximum velocity. So we have a number of Dopplers. One of them is what we call the pulse wave Doppler. So what is the pulse wave Doppler? So when we do ultrasound, we did do some basic ultrasound physics. The sound wave, we can send out the sound wave in pulses that we'll send out, so we send out 4 ultrasound beam and then we stop. And then we send out 4 ultrasound beam and we stop. So we sending out ultrasound beam and then we're waiting for it to come back. So that's what we call pulse wave Doppler. So it measures, when you do pulse wave Doppler, it measures velocity of blood at a single point. The transducer sends out a signal and then wait for the reflected frequency. So you send out a sound wave and then you wait for it to come back. because remember, the sound wave have to travel. It strikes the object or the tissue you want to analyze. It's going to come back to the transducer. So that's what we say. You send out the sound wave in pulses. So that's what we call the pulse wave Doppler. So it sends out the pulse, and then the transducer wait for the reflected frequency. So the transducer is actually alternating between transmission of the sound and the reception of the sound. Okay. When we're looking at certain blood flow in the heart, we gonna either use pulse wave Doppler or continuous wave Doppler. So again, when we're looking at blood flow, so we look at blood flow across the mitral valve, we look at blood flow across the tricuspid valve, we look at blood flow across the left ventricular flow tract, we look at blood flow, the pulmonary vein or the hepatic vein. We use actually pulse wave Doppler for that. So these are the different blood flow that we use pulse wave Doppler. The mitral valve or the mitral inflow, so the flow across the mitral valve in diastole, the left ventricular outflow tract velocity, hepatic vein velocity, and then tissue Doppler imaging. That's a new concept. What we do, we actually look at the tissue moving, because remember the heart is not a static organ. There's the muscle contract, the muscle relaxes, the heart moves up and down. So the heart is a moving organ. So we have something we call tissue Doppler imaging that looks at the mitral annulus and see how well the mitral annulus moves, and that's what we call tissue Doppler. We'll get to that, but this is not actually blood flow, but the movement of tissue. Pulmonary vein flow, we can look at the blood flow into the pulmonary vein, and this helps us tremendously to determine disease state of the heart. Okay, so we can look at pulmonary vein flow and determine what disease the heart is subjected to, and then tricuspid inflow velocity. So these are all the things that you use pulse wave Doppler to analyze. Okay, again, with pulse wave Doppler, you send out a pulse, and the transducer wait for it to come back and receive it. The limitation of pulse wave Doppler can only measure velocity of a certain magnitude. Okay, so as we showed you before, this is your cursor. The sample volume is at the tip of the mitral valve. Again, your transducer is right there. Transducer is right up here. Cursor, sample volume across the mitral valve, and you press your pulse wave Doppler, and you get, okay? So these are diastolic flow. Diastolic flow. Diastole is from the end of the T wave to the QRS. This is flow across the mitral valve. It's above the baseline because the flow is from the left atrium across the mitral valve into the left ventricle. So the flow is going towards your transducer. That is why it's above the baseline. Your E velocity and your A velocity, these are diastolic flows. You have to use pulse wave Doppler. Pulse wave Doppler have a limitation. It can only measure velocity up to about 1.52 meters per second. Again, the left ventricular flow tract, your transducer is right there. The cursor is right there. This is your sample volume right at the left ventricular flow tract. You turn the pulse wave button on and you get this. So this is a flow below the baseline. This is the baseline. The flow is below the baseline. And the reason why the flow is below the baseline, you have a flow, it is moving from the left ventricle across the left ventricular flow tract and moving into the aorta. It's moving away from the transducer. Hence, it's below the baseline. And it's a systolic flow because it occurs from the onset of the QRS to the end of the T wave. It's a systolic flow, okay, below the baseline, LVOT flow. Okay, so the hepatic vein flow, so your subcostal view. So if you remember your subcostal view, you have the inferior vena cava. Joining the inferior vena cava, you have the hepatic vein, and it's going to move away from the transducer. And you're going to get a systolic component and a diastolic component and an atrial flow reversal. So this is what the hepatic vein flow looks like. Systolic component, it moving away from the transducer, hence it's below the baseline. Systolic component, diastolic component, atrial flow reversal. Okay? And this is a pulse wave Doppler measurement. And then we talk about tissue Doppler. We're looking at the movement of the tissue. So this is the mitral annulus right here. You have a medial mitral annulus. You have a lateral mitral annulus. You put this is the cursor, the sample volume is right there, and you just press your pulse wave button. But this is actually tissue Doppler. It's a pulse wave Doppler measurement, but because the velocity is so small, the scale is much smaller. But tissue Doppler imaging is pulse wave Doppler. It's just that the velocity is much, much smaller. So when you look at the medial mitral annulus, okay, so initially in systole, this is going to move up towards the apex, towards the transducer. The transducer is right up here. So in systole, the mitral annulus moves up towards the transducer. So you get what we call a S prime. This is a S prime, telling you that the tissue moves upwards. And then in diastole, the mitral annulus actually moves downward. But there are two components to that. You have an E prime and an A prime. Okay, again, everything we do in echo, we have ECG, it's gated. So you have an ECG on top. This systole is from the onset of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. So when we're talking about tissue Doppler imaging, you have an S prime, which is the systolic component. Systole, the annulus moves upward, and then in diastole, it moves downward. But there are two diastolic components. You have an E prime and an A prime. And the same thing for the lateral annulus. Okay? This is the lateral mitral annulus. So these are tissue Doppler, which is pulse wave Doppler measurements. Again, when we look at pulmonary vein flow, so apical fourth chamber is on top, apical fourth chamber. One of the pulmonary vein is right there, another is right there. If you put this is the cursor, the sample volume is right there. You turn it on, you're going to get something looking like this. Okay. This is the systolic component of the pulmonary vein flow. This is the diastolic component, and then you have an atrial flow reversal. Again, pulmonary vein is right there. You know, the pulmonary vein drains into the left atrium. The pulmonary vein drains into the left atrium. So it's moving towards the transducer. So in systole, when we talk about systole, we're talking about ventricular systole. In ventricular systole, you're going to have blood flow from the pulmonary vein enter into the left atrium. So you have a systolic component. In diastole, you're still going to have blood flowing from the pulmonary vein into the left atrium. So you have a diastolic component. When the atrium contracts, then it push blood away. Push blood into the pulmonary vein away from the transducer. So this would be below the baseline. So again, when the left atrium contracts, it's going to push blood into the pulmonary vein away from the transducer in the opposite direction. So your atrial flow reversal is going to be below the baseline. So this is your pulmonary vein flow, okay? And that's what it looks like. It's a pulse wave Doppler measurement. Okay, tricuspid. So if you were to look at your tricuspid inflow, cursor is right there. Sample volume is at the tip of the tricuspid leaflets. This is your transducer. So you have a diastolic flow above the baseline, and that's because you have flow from the right atrium across the tricuspid valve into the right ventricle. So the flow is moving towards the transducer, it's moving upwards. So you're going to get the Doppler spectral display above the baseline. This is the baseline. So it's going to be above the baseline, but it's going to be diastolic. Okay? So tricuspid inflow is also pulse wave Doppler. Okay? Now, as I've said before, there's some limitation with your pulse wave Doppler analysis. It is limited by the inability to measure high blood flow velocity. So if the blood flow velocity is above 1.5 to 2 meters per second, you can't use pulse wave Doppler. If you use it, something is going to occur. Say, for instance, you're measuring mitral regurgitation, and mitral regurgitation usually have a velocity of 5 meters per second. What it's going to do, when it's reached to the limit of 2 meters, it's going to cut it off, and it's going to put the remaining 3 meters per second below the baseline. So that's what we call aliasing. So aliasing occurs at velocities above 1.5 to 2 meters per second when you use pulse wave Doppler to measure high velocities. And this is what I'm talking about. So aliasing is represented on the spectral trace as a cutoff of a given velocity. So it's going to get to that maximum 1.5, 2 meters, and it's going to cut it off. So this is what I mean. So this patient have aortic insufficiency, and they initially use pulse wave Doppler. So when you get to, so again, velocities on the vertical axis. So this is 1, 2, 3, 4. Once it gets to 2 meters per second, it just cut it off and put the remaining velocity down the bottom. But if you were to use continuous wave Doppler, which measure higher velocities, you can see now this is 1, 2, 3. It can measure this aortic insufficiency, which go a little bit above 3 meters per second. Whereas if you're going to use pulse wave to do it, once it gets to 1.5 to 2 meters, it's going to cut it off and put it down the bottom. Okay, so this is a pulse wave Doppler, and we're going to stop here. And on Wednesday, we're going to look at color flow Doppler and continuous wave Doppler. Okay, so it's a new concept, but if you go over it repeatedly and try to understand, then you will understand it.